Have we wondered how many lives we as people can save just by allowing our women to prepare enough before their pregnancy? And by saying how many lives, I mean lives of the women themselves and that of their unborn babies. Today, we are talking about pre-pregnancy care or pre-conception care. My name is Dr. Edman. You're welcome to my channel. I'm an obstetrician gynecologist, and I'll be sharing some insights about maternal health with you. Don't go away. You might not be the one carrying the pregnancy, but your sister, a friend, your auntie, even your mother might be the one carrying the pregnancy, or your wife. Let's share this insight together. So preparing for pregnancy itself is not any abstract thing, but in our setting in Africa, usually we believe that pregnancy is a gift that just happens to the woman, right? So it's not a Western idea if we allow our women to prepare before pregnancy. So preparing before pregnancy involves that preparing before pregnancy can be done in any hospital, in any healthcare. So let me take you for instance in a district hospital, even the health center. But most importantly, the caregiver should be somebody who is knowledgeable in this preparation. So the ideal would be an obstetrician, a gynecologist, or even a general practitioner. And our midwives can also help to schedule you for an appointment with an obstetrician, or even they themselves can guide you as you prepare for your pregnancy journey. Yes, so the first of it all is that I want you to know that it can be done. It doesn't need to be any special hospital, but rather any well-equipped hospital with a personnel with adequate knowledge can help. It usually starts 3 months before you get pregnant. That's if you don't have any known disease or complication. 3 months before you get pregnant, you can make a decision to attend the pre-conception clinic in any facility of your choice. But if you have an obstetrician, fair enough. And what do we even expect of you when the time comes for you to do or come for the pre-conception clinic? First of all, you have an encounter with a health provider who can be a doctor, midwife, an obstetrician. And the pre-conception care will entail, first of all, taking a clinical history from you, and that will involve the normal question asking. Then thereafter, there will be examination where we want to find out if there's anything generally wrong with you or unwell with you. Your abdomen, our focus will be more in the abdomen and the pelvis. Then the next will be the labs or investigations that will be done for you. So let's start with the history. That's when you approach them first, what sort of questions that you'll be asked by the health worker. So first of all, we want to know, like I said already, your demography, your name, just for identity's sake, your age, the extremes of ages, maybe less than 17 and then above 35, if that's the time you are getting pregnant. Above or below these extremes, your chances of having some complications within the pregnancy could be more. Okay. They also want to find out if you are married or you are already in a relationship. For some people, I mean, the trends are changing, you know. Some people are not, they don't have any partner, but they just want to get pregnant. And now there's a possibility of it where they can be a sperm donor, that a sperm will be injected into you, what we call the intrauterine insemination. So yes, we want to know about your status, your marital status. We also want to know where you stay, the kind of work you do, right? For some people, they are stressed from work, and stress in itself can actually cause some changes in the brain, what we call the hypothalamus, and that has an effect on even how you ovulate or release your egg. And once you are stressed from work, you are not able to ovulate, you know, the chances of you having pregnancy in itself is quite difficult. So some people might need some job modification. The next thing that we do is that we want to find out if currently you have any problem or complaints that you want to tell us. Some people will say, oh, I have some vaginal discharge. Some say, oh, I'm bleeding a lot. And anything that you mention, some will say, oh, I have a mass, a sensation of a swelling in my abdomen, or my abdomen has become bigger, but I've gained weight. These are complaints that you can put across even during the preconception clinic, right? Then, if you have none of these, the healthcare provider will go ahead and start to ask you some questions. So they'll ask you symptoms of anemia. For instance, if your blood level is low, they can ask you, oh, do you have, there's your heartbeat fast and hard? Do you have headaches? Do you usually get tired? Do you urinate a lot? Also about signs of diabetes, do you urinate a lot during the day? Do you drink a lot of water? Do you have do you eat a lot? Do you have the urge to eat a lot? All these things are just to find out if you have any of such conditions. Then afterwards, your provider will still want to go ahead and then do a little more detailed, like asking about your menstrual history. The first time you had your menses, how old you were, okay, and then how your cycle has been. If it's a regular cycle, these days people are easy. It's easy for some people to track their menstrual history because there are apps available that can tell you whether you have a 28-day cycle, 29, 30. Usually the normal cycle is between 21 to 35. If your cycles come too often before 31 days, then you have another one. It's a condition that has to be investigated. Or if it prolongs, goes above 35 days before you have your menses, that's also another thing that calls for concern. So during the preconception, all these will be assessed, right? So aside that, we also want to know if you have used any form of contraception. Some people, they have their cycle distorted because of some contraception they've used. Sometimes even emergency contraceptive, they take it too often as it shouldn't be. This can all alter your cycle. So we need to know if you are currently on any contraception. Sometimes if you are on a contraception, we need to take you off if you are preparing to get pregnant. Okay. So also as part of the menstrual cycle, we also want to know your lifetime sexual partners. Sometimes we do ask because we know the risk that has been involved. Or then after your menstrual history, we also want to know what we call the past medical history. You personally, you want to tell us, you want to find out if you have sickle cell disease, do you have, so these are conditions that when you have, then your care during the pregnancy, we are more cautious when we are dealing with you. We pay more attention to you and we do extra for you. So these conditions can be diabetes, asthma, hypertension, and then what again? I think hyperthyroidism or thyroid disease in itself. These conditions we do have. So if you have any of them, we want to find out if you've been on drugs and how well they've been controlled. For example, if you have diabetes, we want to know if your sugar is well controlled. For some people, their sugars might not be well controlled, and then they will need assistance with, say, endocrinologist or a different doctor coming in to help with making that sure that your sugars are well controlled, because before you can embark on the journey of pregnancy, right? For sickle cell, you want to make sure that it's been a while you had your crisis. You have to be crisis free before you get into pregnancy, because sometimes the pregnancy in itself, it causes you to have a lot of crisis. So we don't want you to be having crisis, then in the midst of it you are getting pregnant. We want you to be stabilized before. The next thing will be whether you've had any transfusion before then, you've had any surgeries. For some people, they've had some, the trends are changing, like I said earlier. So we're having people having pregnant in their later years, maybe after 35 and all. And some people in the black community, they might have had myomas that they've had surgeries for it. And all these make you a high-risk pregnancy. So more attention will have to be paid to you when you are pregnant. Okay. So we want to, apart from the myomectomy, we want to find out if you've had any other surgeries, especially in your pelvis. Then afterwards, we want to find out your drug history. You personally, are you on any long-term medication? Sometimes on the medications, when you are on, we need to take you off the medication or put in a substitute that's safer in pregnancy. For, say, those with sickle cell, we want to, if they are on hydroxyurea, we want to take them off. And then some other medication. So before you go, if you have any drugs that you are on it for a long term, make sure you know the name, or you can tell the doctor what it is. It's very, very important. Then afterwards, we want to find out if you have actually any drug allergies. Then as part of the drug, we also want to put you on folic acid. Folic acid has been popular on the streets in terms of women in the reproductive age, and I'm sure a lot of people you know already. It helps to prevent you from getting your baby having some anomalies, especially the brain and scalp anomalies or the spine anomalies. These are things that are avoided or can be avoided for about 70% of the cases. Okay, so if you have anything of a sort, if you are preparing to get pregnant and then you are not on folic acid, at least 3 months or a month before you get pregnant, we want to put you on it. It helps to prevent the anomalies, helps the baby to form well, and also helps to build your blood level actually. If you are anemic or anything, you also want to start your on some hematinics, encourage good nutrition for you. Yes. Then also social history. These days, Charlie, a lot of guys, a lot of ladies are enjoying life. So some are taking some recreational medications like the opioids or cocaine. Some are also taking alcohol, smoking. So once you make the decision to get pregnant and then you see your clinician, you will be made to put a stop to this. Why? Because, for example, alcohol, very common on the streets, especially if you are taking before or even during the pregnancy. Your child has a tendency of having what we call the fetal alcohol syndrome. And this, you can see that when the baby comes, baby will have some abnormal faces. The nasal bridge, which is, the nasal bridge will be flat, the eyes will be wide apart and small. These are, and not just that, the baby's brain will not be developed so well. So we encourage that women that are trying to get pregnant will abstain or reduce their alcohol, and when they get pregnant, they actually stop the alcohol. All right. So that will be for the social history. There are other things that will be asked, and that will be usually from the responses that you give. Then further questions can be asked. When all this is done, the next will be examination. All right. Okay. So just before the examination, those that have been pregnant before, during the preconception clinic. So preconception clinic is not for those that are trying to get pregnant for the first time, even though it's more important for them. Those that have been pregnant before, we also want to find out how many pregnancies you've had in the past. Has any of them ended up in miscarriages? How many you delivered? Then for each of them, you're actually going to pick each of them and then ask you specific questions. Okay, so before you go, at least know how old your first pregnancy was. During the pregnancy, were you admitted for any condition? Did you develop any condition like diabetes, hypertension? Why? Because in pregnancy or in obstetrics or women's health, a lot of the things tend to recur, right? A lot of them tend to recur. So when you have one condition, don't hide it. Just tell them, oh, during my pregnancy, I actually had, my sugars went very high. So as it was controlled, my baby was even delivered before the 40 weeks. These are things that will guide your doctor, document very well, and then there's actually some screening that can be done for you early in the pregnancy, and some drugs that can be given to you to prevent some of the complications you had in your previous pregnancy from happening again. So don't hide anything. Also, we also want to find out from you if you were actually able to deliver around your due date, or did the baby come too early, or did the baby come some days or weeks after your due date. These are also important. And during the delivery, did you deliver by yourself, or you delivered with assistance? During the delivery, that's via cesarean section or C-section, or during the delivery, did you get any tear that had to be sutured, extensive tear that had to be sutured? Sometimes if we know this and then you plan to get pregnant, when you get pregnant, already beforehand, we know that this pregnancy will be delivered, say for instance, cesarean section. Then we know that, oh, because of that complication you had, say vaginal tear, deep ones, will not allow you to attempt delivery vaginally again. So keep all this in mind. And if you had miscarriage, you should be able to tell us did it happen on its own? In fact, if the pregnancy itself was confirmed, and then if it happened on its own, how many months was the pregnant before the miscarriage happened? These are very important for us because it helps us to know wholly the woman we are dealing with. And then if some procedure was done for you in theater after you had a miscarriage, and afterwards did you have any complications? Some people, after their miscarriage and we have to remove the remaining from the womb, what it tends to happen is that they might have some infection that were treated. Some are not so treated well, especially if the miscarriage or the procedure was done in a setting that was not safe. Okay, maybe just somebody's drugstore and they did it for you. You have some remains inside. You had infection that is blocking your tube. So that one, we know that there's a high index of your tubes blocking if you've been through such an ordeal. So after this history, so the history is thorough. So by the time you come out, or after that, by the time we see you, we know a lot about you, and then how we can help you prevent some complication or to help you to prepare very well before the pregnancy. Then the next thing that we want to do for you is examination. Your doctor or midwife. So right after the history, the next will be for assessment, physical assessment. This physical assessment is to support the history that has already been taken or to find out if there's anything new that was missed. So first of all, your height and your weight will be taken. And by height and weight, so our interest is in calculating what we call the BMI. So the BMI tells us how well, it's an indicator of how healthy the person actually is. Because if your BMI is, the normal one is about 18.5 to I think 24.9. That's the normal range. If you are less than the 18.5, it means that you are underweight or you are thin. It means that you don't have enough stores built to carry you through the pregnancy. And such people, if they get pregnant, there's a tendency of them having miscarriages early in the pregnancy. Or if they should carry it even through the pregnancy, they can deliver or have a preterm delivery, having prematurity, and then it's attendance problems for the baby. So if you are underweight, we want you to put you on diet, get the dietitians in, and then build your store. So you see how important this idea of pre-pregnancy care or clinic is important. Then the next is if you are overweight, okay, maybe above, if you are obese or overweight, let me say BMI is 30, instead of the 18.5 to about 14.9, 24.9, you are hitting 30 and above. Such a person has a lot of risk. The risk could be that during the pregnancy, there could be miscarriages, there could be the risk of having diabetes, hypertension in the pregnancy, or even the babies having some anomalies. And generally, caring for those that are overweight is a bit more difficult, especially right from checking even their BP, sometimes getting, in the African settings, sometimes getting an appropriate size for them to even check their BP is difficult in some settings. Then afterwards, even general examination, when we are trying to palpate the baby, touching the abdomen to find out how the baby is developing is a bit difficult. And during scanning, for ultrasound scan or scan, it uses some sound, right? Sound waves. Sometimes getting fine details on the baby is difficult. So if the baby is having some anomalies or anything, it's easy to miss them, right? If you are obese. So with the background of all these complications for an obese patient or woman who comes for a preconception care, we have to put the patient through a weight reduction care, where it could be diet, lifestyle modification. For some people, the extents can be so, the weight can be so high that we have to maybe start some medication. And some people, they are even refractory to the medications. So what then happens is that surgery has to come in, what we call the bariatric surgeries. And these surgeries, I think, if I'm to mention, because she has also mentioned this herself, Wari Pikin, who is a comedian in Nigeria, has actually done one of these surgeries. But the downside of this is that after you do the surgery, that's what they call the gastric sleeving, right? So they cut part of your stomach away, so you can't eat a lot at a go. Yeah. So what happened? The downside is that when you do such a surgery, you have to wait for like about 1 year before you can get pregnant again. Do you get it? So yes, so we do height, weight, calculate the BMI, then that will be it. Then the next thing will be the general examination, where we also want to check whether there are signs of whether you are pale or not, whether you have some masses in your neck, which is called the goiter. It can have detrimental effects on the baby if it's not controlled. Then we can zoom down, check your feet, and then see whether your feet are swollen. So if your feet is swollen, it could be from either the liver, the heart, or even the kidney. So such a situation, further labs have to be done to make sure that the woman is controlled, or the condition is controlled, before we encourage for pregnancy. Or sometimes even after assessing, we can tell the woman, no, depending on the labs or anything that we have done, we recommend that you don't get pregnant maybe for the next 1 year, or you don't get pregnant even at all. Okay, so preconception care is very important. The next thing after the examination will be to do the labs. All right, so the labs or the investigations, the basic ones that we do, I would just say, first of all, your blood level. Okay, for a woman, we want your blood level to be like, say, 11 and above, so about 15 or 16, right? So if the woman is having, say, a figure that is way below 11, then we need to build the blood level for the woman, either through diet or transfusion, before we can encourage her to get pregnant. And just to chip in that, for a lot of the menstruating young female adults in Africa, most of them, when they come to antenatal, their blood level is below the 11 or even 10, sometimes below 10. So yes, so coming for preconception clinic should actually be encouraged everywhere. And I think that it should even be incorporated into our national health insurance schemes and all that. And then the next will be your blood group. So the blood group itself is not as important, but then what we call the rhesus factor. Okay, so if your rhesus, you are rhesus negative, maybe AB negative, A negative, B negative, or O negative. Because of that negative, it's not a disease per se, but then if you get pregnant with somebody who is rhesus positive, if your husband is rhesus positive, then your baby has a risk of having also rhesus positive, and your body cells or your blood cells will go and attack it. If not the current or the first pregnancy, most of it, the first pregnancy escapes, then the subsequent pregnancies can be attacked by the woman's immune system, and this will cause the woman to be losing a lot of pregnancies. So yes, you see, we can't underrate preconception care. The next will be the normal. Okay, so yes, sickle cell, we want to see whether you are sickling positive or not. And for now, I'm sure a lot of the women in their reproductive ages don't know their sickle cell status. So if you don't know and you are planning to get pregnant, and most importantly, you don't know that of your husband as well, I think you should embark on the preconception clinic and get your sickling status also checked. Then, if you are sickling positive, maybe you are AS, SS, SC, we want to check your husband's own so that we can have adequate information to counsel you. For example, if you are SS or SC and your husband is also AS or also SS, then we can counsel that when you have the chances of your babies having such a condition, if you should get pregnant. But then if you still want to go ahead, we can offer you some other means where we can test the babies that are formed before we give the right ones to you, right? And that will be an IVF where the babies will be tested and know their sickle status before they are implanted or put into the woman's womb to deliver. So yes, then the next ones will be the normal infection screen, like doing hepatitis B or C test for you, doing HIV test for you. These are honestly they are important, because if any of them should come positive, then it means that sometimes we need to start medications. For example, it's currently per protocol in Africa and in my home country, Ghana, if you come with, for instance, HIV positive, we don't even wait, we start medication right away, and then we can do other testings later on. When it's confirmed, we start the medication for you. But for hepatitis B, when it's confirmed that hepatitis B, we need to do, say, your liver testing, liver function testing, to see how well your liver is doing. We can even do a scan to also see how the liver is doing. You can check the number of even the parasites within your body or your blood. These are very important because when you get pregnant, there's a chance of transmitting it to your baby during the pregnancy, during delivery, or even during your breastfeeding. But if you have it and then it's well controlled, and then you get pregnant, the risk of this vertical transmission, as we call it, or transmitting it to your baby, is all reduced. So yes, the impact or the importance of preconception clinic cannot be overemphasized. So after the labs are done, a scan will also be done to see your womb. I know a lot of women are curious to see how their womb is looking at. So the scan can tell us if there's any abnormality or any masses like fibroid or anything in the womb. But straight to say that fibroid in itself is not, will not prevent, it can cause infertility or self-fertility, but most women have, in Africa, a lot of women have fibroids, but then they've still been able to deliver. So maybe when you see that you have it, then we can tell you maybe about you are 28, you have some 2 or 3 myomas, but the positions are not worrying. Then we can counsel you that, oh, so you have these. And once you have these masses, there's a tendency for them to grow, for new ones also to grow. So if you have plans of fertility, then you can decide to have your babies a bit earlier than you had perhaps planned. So yes, these are quite important. And after everything, your history, your examination, and then the testings have been done for you in the scan, then you have another encounter with the doctor. So all this will not be done, say, in one day. Most of it can be done in one day, but then I'm sure there will be a reschedule where you meet the doctor and then you discuss the findings. For most women, they will come out clean, okay? But then a few more, or some women might have 1 or 2 risks that will need some counseling, some medication, or some treatments before they can be encouraged to embark on the journey of pregnancy. So yes, the next time you talk to your sister or your partner or your mom or auntie or anybody that is trying to get pregnant, you can encourage them to have some form of preconception clinic in a nearby hospital, nearby clinic, or to schedule a review and see a gynecologist like any of us, and they will be able to assist you. All this will help to prevent complications during pregnancy or delivery and prevent or reduce maternal mortality and also our babies also dying early in the womb. Thank you very much for listening. I'm sure we'll meet again on a different topic, so you can subscribe if you haven't, and then you can also share the video with anybody that you want to share with. My name again is Dr. Agyemang. Nice having this time with you. Peace out. Have we wondered how many lives we as people can save just by allowing our women to prepare enough before their pregnancy? And by saying how many lives, I mean lives of the women themselves and that of their unborn babies. Today, we are talking about pre-pregnancy care or preconception care. My name is Dr. Agyemang. You're welcome to my channel. I'm an obstetrician gynecologist, and I'll be sharing some insights about maternal health with you. Don't go away. You might not be the one carrying the pregnancy, but your sister, a friend, your auntie, even your mother might be the one carrying the pregnancy, or your wife. Let's share this insight together. So preparing for pregnancy itself is not any abstract thing, but then in our setting in Africa, usually we believe that pregnancy is a gift that just happens to the woman, right? So it's not a Western idea if we allow our women to prepare before pregnancy. So